like to invite Dr. Vivekanand from LVP Bhubaneswar to speak on pharmacological treatment of myopia.
Good morning to everyone. So basically I am going to take you through the pharmacological treatment aspect of myopia. So I do not have any financial disclosure for the slides or the content which I am going to share today. So when we talk about the myopia progression and its treatment, many times we are jumbled with like, okay, I know the things, but sometimes we get confused. All I know is that I do not know anything. Probably when I read a lot of literature coming from different part of the world, and then we get confused. But how do I know this? Okay, so if we see, there are things in place now. What is the definition of myopia, pre-myopia, early myopia? So the literature is very much, and then we have varieties of different consensus guidelines. But then why we are so much worried about the myopia and its progression? If you look at the Global Health Initiative by WHO, the common consensus statement, almost 50% of the children would be myopic by 2050. So that is how we need to be extremely aggressive in treating the myopia progression. So what does we have for the use and efficacy of atropine in myopia progression? I think we have a very landmark studies like ATOM-1, ATOM-2, or recently the LAMP study, which is coming up, and probably we'll have those treatment modalities in our hand in India. And this study population, the only drawback of these studies are their population is East Asian ethnicity. So what about our own population? So yes, we do have a couple of studies and a very good evidence that comes from Saxena et al., Kothari, Agarwal, and Kesarwani. If you see, these are the papers which gives us probably yes, the atropine do work in Indian children's. So this is the consensus guidelines which talks about what does not work, what had the minimal effect, and what appears to work. So what appears to work is the environmental modification, optical treatment, and the pharmacological treatment, which I am going to cover today, the pharmacological treatment. So what is this low dose atropine? So this is the most commonly used method of the myopia control. Large studies, multi-center trials, they have shown that it is effective. And what is the mechanism? Probably stimulating the extracellular matrix by scleral fibroblast, and thus arresting the axial length. So commercially available drop 0.01% found to be effective even in Indian children's. And how does it work? So basically there are three possible mechanisms. One is the release of dopamine in extracellular matrix and vitreous that inhibits the retinal signaling process and thus the axial length. Then release of ECM by scleral fibroblast, and how does it affect the choroidal perfusion and choroidal thickening. So once we understand this, I think at the same time we need to be aware that atropine is not act through accommodative the changes, and it also does not work on the muscarinic receptor as such. So what we learn from ATOM-1 and ATOM-2, I think they are the concentration dependent. 1% what ATOM-1 showed us the light, 77% reduction. Highest effect of 1%, but it has its own side effect like blurring of vision, photophobia, and increased ultraviolet exposure. Contrary to that, ATOM-2 came into the picture where it has given us little broad spectrum of understanding what are the concentration dependent effect of the atropine. So 0.5, 0.1, 0.01%, and that's how we are here because of these studies and their outcomes, that what we understand and practice today. So the major limitation of ATOM-2 even is there was lack of placebo control arm in this particular study. So this is now what currently we are going to understand the LAMP study, where the concentration has increased now from 0.01% to 0.025, and 0.05. So if we understand this, probably this protocol is more or less what we are doing it for, 0.01%. They have divided into 3 arms with 1 more placebo arm, and then followed this patient over a period of 2, 8, and 12 months. So this is the outcome. I think all the eye drops, they have helped to reduce the myopia progression. However, 0.05% seems to be, the most effective concentration. So the conclusion of this study, yes, all drops, they do reduce the myopia. They are pretty safe, well tolerated. However, 0.05% atropine is the best amongst these different concentrations. So do we still have few unanswered questions? Yes, we do have. So like whether the efficacy of both these concentration is going to work for a long term, the rebound phenomenon with both these concentration during washout period is also of concern, and then the efficacy of both these concentration on restarting the treatment in case of the rebound phenomenon. So these are still unanswered question. We have to wait for this to get answers. So what questions probably we are able to answer today? They are like, which is the recommended pharmac agent? I think 0.01%. As of now, we are practicing in India, and we are looking forward for 0.05%. Probably it is coming soon. I think Dr. Saxena is already running a trial in the AIMS. What are the indications? Again, age 5 to 14, simple myopia, increase of the myopia more than, so those are guidelines in place. Where it does not work, I think index or pathological myopia, ROP or the lasered ROP children's. How long to continue for the treatment? As of now, at least for 2 years. How much should we should follow them over a period of every 6 months. When to stop the therapy? Age more than 14 years, or no progression for 2 years when you have treated the patient consecutively. When not to stop? If progression has not reduced by more than 50% of initial progression, and then need to continue for a year. How to deal with the non-responders? Either the high concentration, you can double the dose, or add-on therapy in terms of the optical therapy, which Dr. Sandra Ganesh will talk about. So this is an interesting case I am going to presented to me in 2016, April, 12-year-old male child. So age at presentation was 4 years. Mother was high myopic. The moderate loss of vision probably because of ametropic amblyopia, very high myopia, 28.8 and 28.13 axial length. So if you see the anterior segment, posterior segment, all parameters were normal. Then in 2019, I started this on the atropine 0.01% and followed this patient serially. So in amblyopia clinic recently, we did the detailed workup where what is the sleep hours, what is the near work activity, what is the peripheral hyperopic refractive error, then how much is the outdoor timing. So we start to understand in myopia clinic in detail what's going on with that particular child, and this is what the followed up over a period of time. So 2019 I put them on 1 dose, and still it is going on. Still there is a progression of myopia, possibly because of the COVID time. We don't know, COVID might be the trigger. And then I had to put them on 2 times dose, and it seems to be last 1 year the patient is stable. So I think shifting to the BD dose is one of the consideration. This is another case. First presentation 2018, 6-year-old, mother and father here both are myopic. Okay, so if you follow this patient, you will understand I started atropine 2018 because early age at onset, presentation very young age, and both parents were myopic. So right away I put them on atropine 0.01%. You follow this patient. Again, it seems there is a jump in the COVID time, and then still progressing despite on BD. So again, we don't know. I mean, even BD dose probably is not sufficient enough to really say that the concentration dependent increased doses would help. Third patient, 18-year-old male, moderate loss. There is a kind of moderate amount of amblyopia with this axial length of 24 millimeter. Again, after 1 year, in April 2022, there was a documented progression. Again, put them on atropine, and then you will find that the atropine is working very well even at delayed age at presentation. So this patient was a 15-year-old. So again, the age we need to understand whether, early age it work or whether more than 14 years of age it works. So that's the case scenario. This is another 15-year-old male, the father is low myopic. This case is very interesting. You see the right eye is a high myopia, left eye is a very small amount of myopia. You can see the difference in axial length. So 2022, I started on, obviously I would start the patching along with the atropine drop. And you see that what's happening with this patient, there is a progressive increase in the amount of myopia in an eye which has a less refractive error. Or probably you can call the eye which is being patched. So does patching is the culprit or the other mechanisms where low myopic eye is competing to be like, the high myopic eye, and that there is, the progression of the axial length. So we do not know. So, but not the least can always combine the other optical therapies for non-responders, and probably we have a very good evidence from, the European study where they have looked at the combination of myopia and DIMS glasses, and they are pretty much helpful. They are working together, and probably, that's one of the options. So I want to conclude that the low-dose atropine is a well-proven treatment, relatively cheaper, easy to use, easily available, and almost no side effect. Then can be combined with the DIMS or the other optical treatments in non-responders, which Dr. Sandra Ganesh is going to take forward. Thank you very much.
Thank you, Dr. Vivekanand, for sharing how atropine can be used and how we could probably play around with the dosage to control children who continue to progress